Hi everyone, my name is Courtney Bunner. I'm one of the ID clinical pharmacists at Ruby Hospital. For today's session, I'm going to be talking about highly bioavailable oral antimicrobials. You can go to the next slide. So we'll start out with recalling the benefit of utilizing oral agents over IV therapy, and then identify some highly bioavailable oral agents that we can use, and then review appropriate dosing for oral agents in more severe infections. So to start off, I feel like it's important to understand where the IV only mindset came from and why it's sometimes difficult to change over to oral antimicrobials given this kind of deep-rooted tradition of IV only therapy. So historically, we haven't always had great oral antimicrobials available that have good bioavailability. So starting off in the 40s and 50s, we really only had uncontrolled case series that included some of the only oral agents available, which included things like sulfanilamide and tetracycline, which we don't use anymore. So IV only therapy was really our best option for a difficult to treat infection. And then starting in the 1980s, there were PK and PD testing that were coming out for newer oral agents. But by the time these new PK and PD tests for newer oral agents were coming out, the practice of IV therapy was kind of deeply ingrained in practice and professional guidelines. So to understand the rationale of why oral antimicrobials can be used and to optimize the PK and PD relationship, it's really an important concept to grasp. So antibiotics work optimally under their specific PK and PD index, and we aim to dose them appropriately to achieve their respective concentration time profile. So for example, beta-lactams demonstrate a time-dependent effect on bacterial kill, and an example of how we optimize this is with extended infusion administration times, like with cefepime or Zosyn, or dosing antibiotics more often, like with Keflex every 6 hours. So overall, the likelihood of optimal bacterial kill is linked to the achievement of their target exposure profile. Next slide. So some important considerations for oral antimicrobials is their bioavailability and their drug distribution. So bioavailability is the percent of the oral dose that reaches the systemic circulation intact relative to the IV dose. The bioavailability can be affected by numerous mechanisms, which we can see in the image to the right. So it can be affected by incomplete drug absorption from the GI tract, metabolism within the GI epithelium, excretion back into the GI tract by PGP, or hepatic metabolism or biliary excretion into the GI tract. It's also important to determine drug distribution of the oral agent. So is the drug actually getting to the target site that we're trying to treat? Overall, we should be taking into consideration all of these factors to appropriately utilize oral antimicrobials. And if you hit next, I think there's a box that'll pop up there. So some antimicrobials that are a little bit easier to dose because they have one-to-one IV to PO dosing are listed there. Ones that we often use with our COPAC program would be fluoroquinolones, sometimes fluconazole, linezolid, and then there's some others that aren't listed as well. You can go to the next slide. So why do we use oral antimicrobials versus IV when we know that most IV antibiotics are getting to the target site and have 100% bioavailability? So there's numerous options. A lot of our patients are unable to afford IV antibiotics, or their insurance does not cover IV antibiotics outpatient. So oral antimicrobials are the best option for the patient. It decreases costs for the patient as well as the hospital at times, because it decreases the amount of nursing staff that we need to maintain lines and the time that it takes to switch out antibiotics when utilizing IV therapy. It can sometimes decrease the length of hospital stay as well, decrease rates of line-associated infections, And then sometimes we can use oral antimicrobials that might have a decreased incidence of C. diff infection as well. The next section, I'm just going to be going over appropriate dosing for antibiotics. If you hit next, there might be a box that pops up. Yeah. So if we are unable to use these antibiotics or antimicrobials with 1-to-1 IV to PO dosing, are there other agents that we can use, and how do we dose them appropriately? Next slide. So this is just a quick dosing guide for some more commonly utilized agents that can be used in severe infections and that we commonly use for in the COPAT program that don't have 1-to-1 IV to PO dosing. So they can be a little bit more difficult to dose. These are just some agents that we use in patients that might be on extended therapy for things like gram-negative bacteremia, endocarditis, bone and joint infections, or osteomyelitis in general. And then at times we can use them for more severe MSSA or streptococcal infections as well. These doses are pulled directly from our MedCompass app, which I'll talk a little bit more in detail about a little later on. But this is just an example of how we can dose some of these agents. And as we can see, some of them are dosed at either higher doses or more frequently than maybe if we were to use them, if we were using them for a UTI. So it's really important to consider what we're treating and if we're using the appropriate dose for the indication. Next slide. So I just wanted to talk about the fact that there's so much data out there now for stepping down to oral therapy and more severe infections. I'm not going to go through all of the studies that are available, and I've just listed some, but some I wanted to point out were for endocarditis. There was the famous POET trial that came out in 2019 that really concluded that we can use oral therapy appropriately in certain cases of endocarditis. And then with osteomyelitis, there was the OVIVA trial as well. And both of these are landmark trials. With other indications like gram-positive bacteremia, there is a lack of data, but there are still some studies out there that say that you can utilize step-down therapy with oral agents. Next slide. With gram-negative bacteremia, we actually have a consensus guidance document from 2021 that really does a good job of outlining which agents we can use. Of note, they do recommend against using cefadroxil just for the sole reason that there's a lack of data in gram-negative bacteremia. I think it's more appropriate to say that we shouldn't use cefodoxime or ceftonir in some of these cases just because the bioavailability of those agents are not great. And then more simple infections, we can step down a PO or even start out with PO and UTIs and pneumonia. So making sure we're utilizing oral agents in those infections in particular is important. The next slide. And factors to consider when we're dosing these oral antimicrobials are things like obesity, so taking into account the patient's weight. If the patient's very obese, we might need to dose the antibiotic, especially beta-lactams, even more frequently or use a higher dose. Taking into consideration their renal function, so if they have any renal dysfunction, making sure that we're dose adjusting the antibiotics when it's appropriate. The source of infection, so I touched on drug distribution earlier, making sure that the drug is going to be penetrating and able to get to the site of infection to treat appropriately. And then the organisms identified and if we have any susceptibility data available. Next slide. So in summary, we have a lot of highly bioavailable oral agents that can be used, especially to treat more severe infections now. We should always be taking into consideration these certain factors that I just went over when dosing oral antimicrobials. And if we ever have a question, our WV Med Compass application does a really good job at summarizing doses, and we have many guidelines on different infectious disease states to utilize that with. And we can always ask one of the ID pharmacists as well. We're always more than happy to help dose oral agent. And if you go to the next slide, I put the QR code for the Med Compass app, so you guys can refer to that and download that to your phone, and it's really accessible and really easy to use. It's very, very helpful. And that's all I had for today. If anybody has any questions or comment, I think I saw a question pop up in the chat. When do you use augmentin TID versus BID? So typically, if the patient is more obese, then that's really when we're going to be utilizing the TID dosing versus BID. If they are at a normal weight, then I would feel comfortable using the BID dosing, but that's typically the main factor that I look at when dosing TID versus BID. Any other questions? Comments?
I think you hit it right on when you said the data behind the ability of oral antibiotics to help is there. It's our mindset and transition away from the way we've done things traditionally. In the sense that not only do some patients feel that IVs are better than oral, but our providers as well are still of the general mindset that for the very sick patient, which I can understand, start with IVs, but the step down to oral is still something that I find is more of a practice transformation issue.
Yeah, sure. Yeah. Maybe once the guidelines are updated slowly, it might be a little easier to implement, but unfortunately, it's the slow process of guideline update.
One argument for how to overcome that, the mental barrier is by the counter argument that IV antibiotics have more toxicity to them than oral. So once we start accumulating data saying that, the equivalent conversion to IV for this patient runs twice the risk of harm, including readmissions, including line-related issues, that might help us convince that there's a safety profile to changing to oral.
So we did have two questions pop up in the chat. I've got one that is broad spectrum IV antibiotics in the last 90 days are known to be a risk factor for MRSA, pseudomonas, and overall MDR organisms. What are your thoughts about broad spectrum oral antibiotics as a risk factor?
If a patient has been on an oral antibiotic that's very broad, for example, Levaquin, recovering for Pseudomonas previously, we have to take that into consideration when we're treating a subsequent infection. Like, are we treating them with Levaquin for the reason that they had Pseudomonas isolated in the culture before? And then do we need to keep covering for that? I think those are all considerations to take into account. And I don't think that we should just discount it just because it's an oral antibiotic versus an IV antibiotic, if that makes sense. I don't know if you guys have anything else to add.
Yeah, I think the rationale for worrying about drug-resistant organisms is appropriate if a patient has been on broad-spectrum antibiotics, whether those were administered IV or PO. I think that rationale is appropriate. If a patient's been on, Levaquin for a while or meropenem for a while, obviously then the next bug you'll isolate is going to be something that would be resistant to it. Now, is it a pathogen or not? That's where it's difficult to interpret. So,
Next question, is there a bioavailable threshold you have for PO antibiotics? I believe you said you're not necessarily on board with cefoxiime.
The only comment I had about cefodoxime was in the gram-negative consensus guidance document. They recommend against using it for a step down in gram-negative bacteremia, simply because there's a lack of data with that indication specifically. But I would utilize cefodoxime in other indications as well, like intra-abdominal infections or pneumonia. It really doesn't, I mean, I think the bioavailability is like, if I'm not mistaken, 50%. So it's really not that terrible. I would trust it, and we've used it in patients before. I think the one that am really concerned about is Septanir, because the bioavailability is very low and the urinary penetration is very low. So I don't have a lot of faith in Septanir, really, for any indication.
I agree. And on the Compass site, the bioavailability handout has the percentages for the oral agents that we use a lot in the COPAC program, and even starting out would go to a lot as a reference. About cefodoxime, I remember a patient, actually Dr. Sawaria had seen, was a spine patient, or a cervical spine infection, and had resistance to quinolones. And the regimen included, it was polymicrobial, but there was an E-folate. The regimen included cefodoxime that did very well. So it can be used, but we tend to use, say, if you have the option to use Levaquin, right, it's 99% bioavailable, or moxifloxacin greater than 90%. But look at it more for endovascular infections, serious bone and joint spine infections when we can, not so much urinary tract pneumonias.
Yeah.
I think this is also one of the areas where it's not a black and white answer, in the sense that there probably shouldn't be a bioavailability threshold. I think if you know the bug and you know the MIC and you know the approximate drug level that you're achieving with your oral absorption, whether it is a 50% absorption or a 90% absorption, you can make a pretty educated guess as to whether it will work or not, right? So we've taken care of patients with endocarditis with amoxicillin, not traditionally one of your highly bioavailable drugs, but we knew it was a strep. We knew the MIC was penicillin MIC or amoxicillin MIC less than 0.1. And we know that you're getting a level more than 10 times higher. So I think maybe the nuance here is even a 50% bioavailable drug may be okay if I know the MIC of the bug and I'm getting a level substantially higher.
Thank you, Kelly and the Chantry. The last comment, we invited again our COPAT trial team today to today's meeting, and some hadn't gotten a chance to go through the IACO process. So instructions are all sent out, but did share the link with a few people for that reason. So thank you.
No problem. I'm glad that you were able to join in, but we just want to make sure attendance purposes. So
Thank you.
yeah. All right. Do you have anyone other questions? We can put them in the chat. I just want to give an opportunity before we move on to cases. I'll do the famous echo pause in case anyone's fingers are frantically typing.
Only other thing about using oral antibiotics and just as you use them and see patients do well, hearing cases like this, participating in the have patients in the COPAT program that you follow, comfort level continues increasing. So, in addition to the guidelines, just being it in patients, routine practice. Move on to the cases.